Good afternoon, everybody. Dr. Podcheko is here. Today's lecture topic is clinical anatomy of thyroid in parathyroid glands. Let's take a quick look on what we are going to learn today. Basically, at the end of this lecture, you should be able to first describe the anatomical location of the thyroid gland. Second, be able to identify cells responsible for production of thyroid hormones, target tissue, and functional outcomes of the endocrine hormones from the thyroid gland. Also, you need to be able to describe the blood supply, innervation, lymphatic drainage, understand the embryological derivatives of the thyroid gland, understand basics of medical imaging of thyroid gland. As well, we will review clinical correlations to help with understanding the practical value of anatomy of the thyroid gland. So, based on my own experience, I would like to emphasize that for medical doctors it is very important to know thyroid gland anatomy. Keep in mind that more than 12% of US population suffer from thyroid gland diseases, and thus, regardless what kind of specialization you will choose in your future career, earlier or later you will have to deal with thyroid gland pathology. Even though most of the thyroid gland diseases, chronic, long-standing diseases, the thyroid cancer in some cases may be quite aggressive and may cause death within short period of time, sometimes half years, sometimes 1 or 2 years after clinical manifestation. In order to understand how to diagnose and treat thyroid gland diseases, knowledge of thyroid gland anatomy becomes absolutely necessary. Also keep in mind that clinically important aspects of thyroid anatomy are frequently tested on the board exams. So from what we will start? We will start discussion of thyroid gland anatomy from reviewing important structures which forming viscera of the neck. Particularly, you should understand that cervical viscera, or organs if you would like, are forming three important layers, named by their primary function. Superficial to deep, they are endocrine layer, which will be covered in this lecture. This is thyroid and parathyroid glands. And this is most superficial actually layer of cervical viscera. On this transverse section of the neck, at the level of second tracheal ring, this layer is shown in pink. Second is the respiratory layer formed by larynx and trachea. On the figure, this layer presented by trachea in blue. And the third layer, alimentary layer, presented on this section by the esophagus. To get better understanding of thyroid gland anatomy, let me review on couple slides most important concepts related to the function and histology of thyroid gland. On the next slide, and the next few slides actually, I placed the most important information about thyroid gland physiology. Before this lecture, you already should know that our endocrine system consists of glands which release their secretions or hormones into the bloodstream in order to act on the target cells. Thyroid glands, by the way, largest endocrine gland of our body, produce thyroid hormones and calcitonin, so two types of hormones. So let me tell you a little bit about hormones produced by thyroid glands. T3 or triiodthyronine represent 20% of total pool of thyroid hormones and has highest metabolic activity. T4, also known as thyroxine, represents remaining 80% of the secreted thyroid hormones and has actually pretty low metabolic activity. T4 can be converted into T3, which is an active form of thyroid hormones, and this is done usually by enzymes called deiodinases, which are present in cytoplasms of various cells. So T3 and T4 both regulate the basal metabolism and heat production of cells and tissues and influence body growth and development, but we will talk more about functions of thyroid hormones a little bit later. Also pay attention that for synthesis of thyroid hormones, important chemical element iodine is needed. Now regarding another thyroid hormone, which we called calcitonin. It functions as a physiologic antagonist to parathyroid hormone because it lowers blood calcium level by suppressing the resorptive action of the osteoclast and by enhancing calcium excretion through the kidneys. This hormone also targets the rate of osteoid calcification by promoting calcium deposition in bones. Release of calcitonin from thyroid gland is influenced by circulating blood calcium levels, and high levels stimulate secretion, low levels prevent it. Next slide. Functions of thyroid hormones are multiple, and most of them are directed to increase basal metabolic rate in the cells and organism. I'm talking, of course, about T3 and T4 hormones. Thyroid hormones normalize insulin level, it is well-known fact, improve insulin resistance, increase glucose use for ATP production, promote breakdown of fat into energy, and increase oxygen consumption and use ATP by cells. So pretty multiple functions. More details you get in physiology lectures. And this last slide on the thyroid hormone action, I just would like briefly to say that here is shown that T4 can be converted by enzymes called deiodinases into T3, and this process happens in cytoplasm of human cells. And T3, thyroid, is capable to bind to specific so-called nuclear thyroid receptors, which acts as modulators of transcription. So those proteins act as modulators of transcription. As a result, cells will modify expression of various proteins, and this will lead to growth and differentiation of various types of cells. Thyroid hormones, through various mechanisms, facilitate normal mental development, increase the local effects of catecholamines, and more details, as I said, you will get in the physiology course. That will be enough for you to understand basic concepts behind thyroid hormone action so far. So let's discuss briefly histology. Before jumping into anatomy of thyroid gland, let's review briefly histology of thyroid gland. So the microstructure of thyroid gland consists of thyroid follicles, and thyroid follicle can be identified in light microscopy as a spherical pool of colloid with walls of simple cuboidal and columnar epithelial follicular cells. Hundreds of thousands of these colloid pools constitute the majority of the gland tissue, making thyroid recognizable on routine hematoxylin eosin stain, as it's shown here, as a system of bright pink containers of gel-like colloid fenced in by hormone-releasing follicular cells which have strong basophilic nuclei. Follicular cells produce thyroid hormones and concentrate iodine from blood, and their cell surfaces possess thyroid-stimulating hormone receptors, TSH receptors, which binds thyroid-stimulating hormone, which hopefully you remember released by adenohypothesis. Okay, the principal component of the eosinophilic colloid seen in routine hematoxylin and eosin preparations, as is shown on this section, called thyroglobulin. Alright, colloid or thyroglobulin. This is an inactive storage for the T3 and T4 hormones, and keep in mind that thyroglobulin by itself is not a hormone, it's a kind of storage form for the hormones. Parafollicular cells, which you can see here, and they also called C cells, located along the periphery of thyroid follicles within the thyroid gland tissue. These cells do not come in contact with follicular colloid, and their main function is to secrete calcitonin. Thyroid gland location. Let's now talk about anatomy of thyroid gland. The name thyroid derives from the name of thyroid cartilage, and thyroid cartilage resembles the shield, and thyros in Greek means shield. The gland is located close to thyroid cartilage, and that is why it's called thyroid gland. Thyroid gland lies in anterior compartment of the neck, somewhere on the level of C5 or T1, specifically under two muscles, one called sternohyoid and another sternothyroid, which are part of so-called strap muscles of the neck. In 50% of thyroid glands, there are two lobes, and those two lobes, as it's shown on this slide, are united in front of trachea, specifically in front of the second, third, and fourth tracheal rings. Each lobe has pear-like shape and has upper pole and broader inferior pole. The structure which uniting two lobes called isthmus. Isthmus is located usually anterior to the second and third tracheal rings, and please keep in mind, from clinical point of view, very important to understand that in significant number of cases, isthmus may be incomplete, and as a result, there will be no communication between left and right lobes. As I said before, in 50% of cases, thyroid gland has two lobes only. But in the rest of cases, thyroid gland also has a lobe which we call pyramidal lobe. This lobe, pyramidal lobe, which varies in size, extends superiorly from the isthmus of thyroid gland, usually to the left of the median plane, somewhere above the left lobe. In some cases, the top of pyramidal lobe is connected with hyoid bone by a piece of fibrous tissue, which may contain muscle fibers, called levator glandular thyroidy, a levator of thyroid gland. Very interesting muscle. The presence of this muscle does not involve in the movements of thyroid gland, so keep in mind that thyroid gland is moving during process of swallowing because it's enclosed into pretracheal fascia, which is attached to the larynx and hyoid bone, and those two structures are moving during swallowing and thyroid gland moving with them. Also, the band of connective tissue often contains accessory thyroid tissue, which continues from the apex of pyramidal lobe to the hyoid bone. Let's go to the next slide. So now let me try to answer an important clinical question. What would be the best way to visualize thyroid gland in clinical settings? The techniques of thyroid imaging are evolving with progress in the physics and electronics. But for many years, the most well-approachable, most well-known techniques of thyroid imaging and most reliable techniques, I would say, are thyroid scintigraphy, ultrasonography, and cross-sectional imaging by means of computer tomography and MRI. Scintigraphy is a procedure producing frontal images of thyroid obtained within 15 to 30 minutes after intravenous injection of small doses of radioactive technetium-99 pertechnate, or 3 to 24 hours after oral injection of radioactive iodine-131. So the technetium and iodine have kind of similar chemical features, and both can be easily trapped by thyroid follicular cells and partially converted into colloid. So what would be the most common indications for scintigraphy? Among the most important are to relate the general structure of the thyroid gland to its function. For example, nodule, whether it's active or not. To locate ectopic thyroid tissue, for example, lingual tissue, which we will be discussing, lingual thyroid tissue. And third most common indication to evaluate a neck or substernal mass. On the right side of the slide, you can see all steps of thyroid scintigraphy: injection of a radioactive isotope, recording isotope emission from the structures of the neck, and two pictures on the bottom show two lobes of thyroid connected by isthmus, and the shape of looks like a butterfly. Images can be monochrome or could be color, and different colors indicate usually quantity of radioactive material trapped in thyroid. On this slide you can see results of scintigraphy of absolutely healthy normal thyroid, and you see that there is a homogeneous distribution of isotope, more intensive accumulation of isotope in the middle portion of both lobes, and it's just this accumulation in the middle portion indicator that the gland reaches maximal thickness in those areas. Another imaging technique of thyroid is ultrasonography. As you can see on this slide, it should be performed with neck in moderate hyperextension position. Thyroid gland can be imaged in the longitudinal or transverse sections or planes. On the bottom picture, you can see that this technique can give you pretty fair understanding of size, structure, presence or absence of nodules, cysts of thyroid gland, anatomical structures which surrounding thyroid gland, and so on. Among indications for ultrasonography, the most important to consider evaluation of the presence, size, and location of thyroid gland, evaluation of thyroid gland for presence of suspicious nodules, evaluation of the locations and characteristics of palpable neck masses, including enlarged thyroid. This technique provides pretty good outlook on the anatomical structure of the gland, volume of the gland, surroundings of the gland. But you should understand important concept that ultrasound will not help you to answer on the question about ability of the gland or nodule in the gland to trap iodine. So the functional activity of a tissue not so well can be evaluated by thyroid ultrasonography, or cannot be evaluated even, we can say. Now back to our thyroid gland anatomy. Let's talk about thyroid gland capsule. This is next important anatomical structure we need to discuss. The thyroid gland is surrounded by thin fibrous capsule, which you can see here on this picture, covering surface of thyroid gland. The capsule sends septa deeply into the gland, and dense connective tissue attaches the capsule to cricoid cartilage and superior tracheal rings, as it's shown here. This next slide shows you that external to this capsule there is a loose sheath formed by the visceral portion of pretracheal layer of a deep cervical fascia, which is also called as a pretracheal fascia. Let's review this transverse section of the neck. There is a platysma under skin, and below platysma there is a layer of deep cervical fascia, shown here in a red line, which surrounds sternohyoid and wrapping sternohyoid and sternothyroid strap, so-called muscles. Under strap muscles, we see a thyroid gland surrounded by pretracheal fascia. As you can see that behind the thyroid gland isthmus, there is a trachea, and beneath trachea, esophagus. Now we need to understand very important clinical concept. Please remember that upper pole of thyroid gland cannot expand above point of attachment of sternothyroid muscle. You should be aware that sternothyroid muscles are attached onto the oblique lines of the thyroid cartilage. But at the same time, there is no limitation to downward expansion of thyroid gland. As a result, pathologically enlarged thyroid glands, such a clinical situation actually called goitre, enlarged thyroid gland called goitre, has to occupy space behind the sternum. This is what we call retrosternal goitre. And the next slide shows you if thyroid gland become enlarged and most of gland is located behind the sternum, doctor actually may not be able to detect this tissue during visual examination of patient neck. Best approach to confirm presence of retrosternal goitre would be computer tomography. Specifically, sagittal and median section would be most beneficial to take a look at in order to confirm diagnosis of retrosternal goitre, as it's shown on the CT. Here is 44-year-old woman had significantly enlarged thyroid gland due to hyperactivity of thyroid gland, which was caused by defect in the function of immune system. This disease called diffuse toxic goitre or Graves' disease, and we will discuss a little bit later. Let's continue with anatomy. Let's talk about arteries of thyroid gland. Thyroid gland is highly vascular, and gland is so important that it takes 5 times more blood per unit weight than the kidneys and 25 times more than the brain. Approximately 100 milliliters of blood passing through the gland per 1 minute. Mainly, thyroid gland is supplied by 5 arteries: 2 superior, 2 inferior thyroid arteries, and Thyroid Ima Artery, which is not shown on this figure. And I have to admit there are also many small anastomoses with other arteries of the neck. On this figure, pay attention that you are looking on the thyroid gland from the behind of esophagus and pharynx. So this is posterior view. As you can see here, superior thyroid artery is the branch of the external carotid artery, just distal to its bifurcation. Here you can see how superior thyroid artery reaches the pole of thyroid gland and divides on anterior and posterior branches. Very important from clinical point of view to remember that superior thyroid artery is accompanied by external branch of superior laryngeal nerve. Let's together review this slide. Superior laryngeal nerve is the branch of vagus nerve. Superior laryngeal nerve, as it's shown here, has 2 branches, internal branch and external branch. Internal branch provides somatic sensory innervation to the larynx above vocal cords, epiglottis, and vallecula of the tongue. External branch innervates cricothyroid muscle and part of inferior pharyngeal constrictor muscle. Remember very well that cricothyroid muscle is responsible for increased tension of the voice cord. And regarding arteries now, superior thyroid artery, as it can be seen here, at its beginning provides a small branch which passes through thyrohyoid membrane. This membrane is connecting hyoid bone and thyroid cartilage. And this little branch called superior laryngeal artery. This artery is accompanied by internal branch of laryngeal nerve. The remaining part of superior thyroid artery approaches superior pole of thyroid gland. And this remaining part of superior thyroid artery is closely related to the external laryngeal nerve innervating the cricothyroid muscle. And this nerve can be easily injured during ligation of superior thyroid artery during surgery. That is why it is so important to remember this concept. A superior laryngeal nerve injury will lead to the changes in the pitch of the voice and causes an inability to make explosive sounds due to paralysis of cricothyroid muscle, the muscle which increases tension of the voice cord. Bilateral injury of this nerve will lead to the presence of a tiring and hoarse voice. Let's summarize what we learned regarding relationship between superior thyroid artery and superior laryngeal nerve. Superior thyroid artery is closely related to external laryngeal nerve at its origin, as it's shown on the image. Nerve moves away from the artery as artery approaches the upper pole of a gland. In order to avoid injury of external laryngeal nerve, the superior thyroid artery needs to be ligated during surgery just near the superior pole of thyroid. A superior laryngeal nerve injury will lead to changes in the pitch of a voice and cause inability to make explosive sound due to paralysis of cricothyroid muscle, as I said before. Now let's talk about inferior thyroid artery. Inferior thyroid artery is a branch of the thyrocervical trunk arising from the subclavian artery. The inferior thyroid artery makes a bend and it looks tortuous due to the fact that thyroid gland is moving up and down during each swallowing. If this artery would not have ability to extend, it would be traumatized during movements of larynx and thyroid gland. Inferior thyroid artery bends above the lower pole of thyroid lobe and divides before entering into gland into multiple branches. The right and left superior and inferior thyroid arteries form anastomosis connections within the gland, providing collateral circulation between subclavian and external carotid arteries. Another clinically important concept we need to discuss is anatomical relationships between recurrent laryngeal nerve and inferior thyroid artery. Let me remind you a little bit about recurrent laryngeal nerve. This nerve, as a superior laryngeal nerve, is a branch of the vagus nerve. The left recurrent laryngeal nerve passes in front of the arch and then wraps underneath and behind it. Branches of recurrent laryngeal nerve then pass behind the thyroid gland and enter the larynx underneath the inferior constrictor muscle. This nerve innervates all the intrinsic muscles of the larynx with the exception of cricothyroid muscle. Remember that one was superior laryngeal nerve. Injury to the recurrent laryngeal nerve can result in a weakened voice, hoarseness, or loss of a voice, which is called aphonia, and cause difficulty breathing due to paralysis of posterior cricoarytenoid muscle, responsible for opening the vocal cords. The terminal branches of inferior thyroid artery are tightly related to recurrent laryngeal nerve. Let's take a look at this slide to understand this important concept. Most commonly, recurrent laryngeal nerve passes behind the inferior thyroid artery, but sometimes it passes between branches of inferior thyroid artery or even in front of terminal portion of inferior thyroid artery, exactly as it's shown on this picture. Therefore, it is important to keep in mind that someone performing ligation of inferior thyroid artery, it is possible to injure the nerve during ligation of inferior thyroid artery. Thus, it is advisable to ligate inferior thyroid artery far away as possible from thyroid gland, well before the inferior thyroid artery begin to divide on small branches. In such case, there is less probability to injure recurrent laryngeal nerve during ligation or of inferior thyroid artery. Alright, now let's talk about Thyroid Ima Artery. In approximately 10% of people, a small unpaired thyroid artery called Arteria Thyroid Ima or Thyroid Ima Artery arises from brachiocephalic trunk. However, it may also arise from the arch of aorta or from the right common carotid, subclavian, or internal thoracic arteries. This small artery ascends on the anterior surface of the trachea, which supplies and continues to the isthmus of thyroid gland. There it divides and supplies it. For doctors, it is important to remember about this artery. The possible presence of this artery must be considered when someone performing procedures in the midline of the neck, just inferior of the isthmus of thyroid gland, specifically procedure called tracheotomy. Cutting this artery may be cause of a serious, even lethal bleeding for the patient during tracheotomy. Please keep it in mind. Next topic is anatomy of thyroid gland veins. There are 3 pairs of thyroid veins draining thyroid gland. They usually form a thyroid plexus on the anterior surface of thyroid gland and anterior to the trachea. It is quite important to know that superior thyroid veins accompany the superior thyroid arteries, and those veins drain the superior poles of thyroid gland. The middle thyroid veins do not accompany by arteries, but run actually almost parallel courses with inferior thyroid arteries, and they drain the middle portion of the lobes. And lastly, inferior thyroid veins, they accompany the Thyroid Ima Artery, if Thyroid Ima Artery is present. As it's shown on this slide, superior and middle thyroid veins drain into the internal jugular veins. Inferior thyroid veins drain into the brachiocephalic veins, posterior to the manubrium of the sternum, and blood from all above mentioned veins, as you see, is drained into superior vena cava. Here's another figure demonstrating your venous drainage of thyroid gland. Again, superior and middle thyroid veins drains into internal jugular veins. Inferior thyroid veins drains into brachiocephalic veins posterior to the manubrium of sternum. Let me review lymphatic drainage of thyroid gland. Thyroid carcinomas are the most common type of malignant tumors affecting endocrine glands. The malignant cells forming thyroid carcinomas have propensity to spread through lymphatic vessels and grow as metastases in lymphatic nodules of the neck. As a result, a presence of enlarged lymphatic nodes on the neck may be the first sign of thyroid cancer. That's why it's so important to understand lymphatic drainage of thyroid gland. Thyroid lymphatic vessels, which embedded in thyroid gland stroma, communicate with 2 lines or 2 levels of defense in form of lymphatic nodules. First level is formed by prelaryngeal, pretracheal, and paratracheal lymph nodes. Second level is formed by superior deep cervical nodes, which draining lymph from prelaryngeal nodes, and inferior deep cervical nodes, draining the pretracheal and paratracheal nodes. Some lymphatic vessels may drain into the brachiocephalic lymph nodes or thoracic duct, but I will show you this on the next slide. And on these 2 pictures you can see thoracic duct, which can collect lymph from the thyroid gland, and as a result we may expect presence of thyroid cancer metastasis in the bodies of vertebral bones as well. On the left picture you can see lymphatic structure of superior mediastinum and chain of brachiocephalic nodes, which also collect and filter lymph from thyroid gland. As a doctor, you have to be aware about such details of thyroid gland lymphatic drainage, as it will help you to avoid missing the metastasis of thyroid carcinoma, and as a result it may save patient's life. Now it's time to talk about innervation of thyroid gland. I mentioned before two branches of vagus nerve, particularly superior laryngeal nerve and recurrent laryngeal nerve, and their specific relationship with arteries supplying thyroid gland. You should be aware that there is no clear indication that vagus nerve participates in innervation of thyroid gland. The nerves which actually supply thyroid gland derived from the superior, middle, and inferior cervical sympathetic ganglia. They reach the gland through the cardiac, superior, and inferior thyroid, so-called periarterial plexuses, that accompany thyroid arteries. These fibers are actually vasomotor, not secretomotor, and their major function is cause vasoconstriction and regulate amount of blood flowing through the thyroid gland. Endocrine secretion from thyroid gland is hormonally regulated by pituitary gland or hypophysis and also hypothalamus through secretion by those glands and structures specific hormones which call thyroid stimulating hormone and thyrotropin releasing hormone. You will learn this eventually in physiology. That's pretty much all about anatomy. Let's discuss now thyroid gland development. Let's review key points of thyroid gland development. Major event which lead to the development of thyroid gland happen between week 3 and week 7, or let's say major events which lead to development of thyroid gland happens between week 3 and week 7. During the third week of embryonic development, a thickening forms in the floor of the primordial pharynx between the first and second pharyngeal pouches. This thickened region of endoderm invaginates ventrally into the surrounding splanchic mesoderm to form the thyroid primordium. The thickening of the endodermal cells grows and forms the thyroid diverticulum, which appears caudal to the median tongue bud in the fourth week of development. Within next week, it forms tubular duct, which is called Thyroglossal duct, the tip of which bifurcates and this tissue mass grows. From this, isthmus and lateral lobes of the gland develop, and this is actually main anatomical parts of the gland, as you remember. Then thyroid gland migrates down to the neck, and by 7th week, it reaches the final position in relation to the larynx and trachea. There are a few additional important facts I need to mention regarding thyroid gland development. The thyroid diverticulum is connected to the pharynx by the thyroglossal duct, and the site of connection makes a foramen in the adult tongue, which called foramen cecum. As the thyroid glandular tissue migrates inferiorly, the duct portion begins to involute. The distal part of the duct may develop to form the pyramidal lobe of the thyroid gland, but it is important to keep in mind that thyroid gland may develop in any part of thyroglossal duct, and such situation may result in formation of lingual, suprahyoid, retrohyoid, infrahyoid, and even retrosternal thyroid tissue, as it's shown here. And last remark regarding the gland development. Thyroid gland is relatively large in newborn babies, with long narrow isthmus connecting two lobes, and become half of adult size in the 2 years of age. At 2 years of age. Let's go to next slide. Thyroglossal duct cyst. Now let's talk about deviations from normal development of thyroid gland. And first pathology I would like to mention is thyroglossal duct cyst. Thyroglossal duct normally disappears, as I mentioned before, after thyroid reaches its normal position, but remnants of epithelium may remain and form a thyroglossal duct cyst at any point along the path of thyroid gland descent. The cyst is usually near or within the body of hyoid and forms a swelling in anterior part of the neck, always on the midline of the neck, and this is very important to understand. The cyst gradually increased in size and may reach size from 1 to 4 centimeters in diameter, and usually this is happened when person reaches puberty or even later in life. Histological examination of thyroglossal duct cyst reveals cystic structure lined by stratified squamous epithelium. I will show you this a little bit later, and cyst may harbor lymphoid aggregates or remnants, and this is most important, of recognizable thyroid tissue. And presence of this recognizable thyroid tissue is an important diagnostic sign. This could be important for doctors as it helps to differentiate thyroglossal duct cyst with other pathological nodules rising on the neck. On this slide is shown histological examination of thyroglossal duct cyst, probably biopsy, and you see remnants of recognizable thyroid tissue in the form of thyroid follicles. So how will be in the clinical vignette form tested concept of thyroglossal duct cyst? Here is an example of typical vignette on thyroglossal duct cyst. 16-year-old girl has noted a lump on her neck for the past 3 years. On physical examination, there is a firm, non-tender, 2 centimeter discrete mass on her anterior neck at the level of the hyoid bone. Which of the following is the most likely diagnosis? Right, so thyroglossal duct cyst. Next anomaly of thyroid gland we need to briefly discuss is the ectopic thyroid gland. Here is important to understand that in some situations thyroid gland fails to descend from its embryonic origin in the tongue, resulting in ectopic thyroid gland. We can define ectopic thyroid gland as a presence of thyroid tissue in locations other than normal anterior neck region. It means between the 2nd and 4th tracheal cartilages. According to research, the ectopic thyroid gland is the most frequent form of thyroid dysgenesis. 60% of cases of all thyroid dysgenesis presented by ectopic thyroid gland. There are several variants of ectopic thyroid gland. Lingual thyroid gland is considered most common form. Next is sublingual, which could be suprahyoid or infrahyoid, and other ectopic variants when thyroid gland is associated with trachea, submandibular area, lateral cervical regions, axilla, palatine tonsils, carotid bifurcation. There are casuistic cases of ectopic gland when glandular tissue was found in the iris of the eye and pituitary gland. The important for doctors to understand the differences between ectopic thyroid gland and thyroglossal duct cyst. Diagnosis of thyroglossal duct cyst assumes that there is thyroid tissue present in the cyst and in the normal thyroid gland location. But in the case of ectopic thyroid gland, all thyroid tissue is outside of the normal location. In such case, removal of ectopic gland will lead to profound hypothyroidism and lifelong hormonal replacement therapy, which is not so difficult but still pretty serious problem. So, and it's purely will be your mistake, so that you didn't perform proper examination and remove all thyroid tissue. This slide provides more explanation about accessory thyroid gland. We can define accessory thyroid gland as a presence of additional tissue in locations other than normal anterior neck region, along with normally positioned thyroid gland. Accessory thyroid glandular tissue may appear anywhere along the embryonic course of thyroglossal duct, for example, in the thymus, inferior to the thyroid gland, or in the thorax. So, accessory thyroid tissue may develop in the neck lateral to thyroid cartilage, and its quite common location is on the thyroid muscle, like it's shown on this picture. Although the accessory tissue may be functional, it is often insufficient in size to maintain normal thyroid gland, well, that's normal thyroid hormone level, so, and as a result function. And if the thyroid gland is removed, so this tissue is not sufficient to keep level of hormones in physiological range. Let's talk about another very common thyroid disease, is goitre. We can define goitre as a non-neoplastic and non-inflammatory enlargement of thyroid gland. Exception from this definition would be enlargement of thyroid gland that may occur during menstruation and pregnancy. It is very important to remember most common causes of goitre. Iodine deficiency being most common cause in the world, not in USA. So, and keep in mind that every day we need approximately 150 micrograms of iodine. Lack of iodine in food, and you know maybe that highest content of iodine could be found in the food like fish, right, sea products, will lead to development of goitre. In USA, most common causes of goitre are not directly linked to the lack of iodine. Why? Because in United States, widely used iodized salt. But most of the cases of the goitre in United States related to various autoimmune diseases of thyroid gland, such as Graves' disease and autoimmune thyroiditis. Another important concept you should keep in mind is that goitres can be associated with increased or decreased production of thyroid hormones. Goitre associated with elevated levels of thyroid hormones is called toxic goitre due to detrimental or toxic effects of thyroid hormones, excess on central nervous system, cardiovascular system, and other systems of the body. Also keep in mind that enlarged gland causes swelling in the neck that may compress trachea, esophagus, and recurrent laryngeal nerve. This slide shows you classification of a goitre. As I mentioned, goitre can be toxic and non-toxic based on results of examination levels of thyroid hormones. It can be diffuse, nodular, and multinodular based on examination of thyroid gland morphology, and as it's shown on this slide. And to finish with thyroid gland kind of anatomical correlations, I have to mention about thyroid cancer. It is most common type of endocrine cancer, though it's pretty rare in general population. Female predominance has been noted. In contrast, cases presenting in childhood and late adult life are distributed equally among males and females, which is what is indicating us that estrogens definitely have some role in induction or progression of this type of cancer. It is most important to keep in mind that most thyroid carcinomas, except medullary, are derived from follicular epithelium, and there are four types of carcinomas, right? Papillary, which represent 85% of all cases. This is most common type. If somebody asks you what is most common type of thyroid cancer, papillary carcinoma, high yield for USMLE. Follicular carcinoma, approximately 5%. Anaplastic carcinoma, the worst form of cancer, less than 5%, and medullary carcinoma, also approximately 5% of cases. So remember that major type of treatment for thyroid carcinomas is thyroidectomy, and that's why you need to know very well thyroid gland anatomy in order to perform correctly thyroidectomy surgery. Let me talk about thyroidectomy. I was assisting in this type of surgery on several occasions. In most of cases, procedure is quite fast, and subtotal excision of thyroid gland in uncomplicated cases can be completed within 30 to 45 minutes. There are several indications for thyroidectomy. The most common, as I mentioned on the previous slide, are thyroid cancer and goitre, usually toxic type of goitre or multinodular goitre. As a future doctors, you should be aware that in the case of thyroidectomy for treatment of toxic goitre, the posterior part of each lobe of enlarged thyroid gland is usually preserved for two reasons. First, to protect the recurrent laryngeal and superior laryngeal nerves from injury. Second is to spare the parotid glands. Parathyroid glands, not parotid, parathyroid. Collar incision is usually used as it's shown on this picture. The incision should be created in the curvilinear fashion with skin crease approximately 2 centimeters or 2 fingers breadth above the superior edge of the clavicle and sternal notch. Use of an intraoperative recurrent laryngeal nerve monitoring allows for an intraoperative assessment of the nerve function. So before, during, or after removing gland, it's very important to monitor whether you're damaged or not recurrent laryngeal nerve. So, and among complications you should be aware of thyroidectomy are post-operative hemorrhage, is understandable, and hematoma may compress trachea, making difficulty, breathing difficult. And second important complications, commonly tested on USMLE and happens in real life, hypocalcemia, due to removal of parathyroid glands. This will require monitoring of calcium level and clinical signs of hypocalcemia within first week after thyroidectomy. Very important to monitor, because a hypocalcemia may lead to the serious consequences and may potentially cause death of the patient. So, and this is the end of the lecture on clinical anatomy of thyroid gland, clinical correlates. So next topic is clinical anatomy of the parathyroid gland. Have a nice day and goodbye.